possible. I appreciate that everybody wants to catch up after having not seen each other for at least a month. And it's great to have you all here. Sorry about the food being a little bit late and our late start time because of that. We do have a fantastic program today, and I think if you would just enunciate loudly, we should start by going around the room and just say your name and your organization. And before I do that, I had asked Megan if she would be in the room for this, but I think she's distracted. I just want to say thank you to Brian Vaughn. Could you stand and wave? And Megan Olson, our two UC Berkeley student assistants, who graduated this weekend and will both be working on us this year.
Thank you.
So the Right Care Initiative, as you all know, is a collaborative. We've been meeting in this room, believe it or not, since 2012. And we're very grateful to the Sierra Health Foundation for hosting us here. We are powered by your volunteerism and your support and our student and faculty labor. And this is a wonderful forum for people to get to know each other. Once Megan settles down, I'll just have her wave and we can do a congratulations to her also. Sorry. So we have a lovely new aspect to our work, which is that Dr. Matthew Wanacott, who's recently retired from the Air Force as a colonel in charge of Travis Air Force Medical, joining us as our co-chair, along with Dr. Bill Baumer. And so Dr. Wanacott comes all the way from Lake Tahoe to be with us. Come speak with us, and let's everyone go around the room and introduce yourselves. If you have a microphone that you can distribute, that would be fantastic.
So I will go last and introduce myself. So we'll start over here on the right side, and we'll just pass that around. Thank you, Brian. There you go.
Thanks. Hi, everyone. I'm Rhiannon Archangel with the American Heart American Stroke Association. I'm the Vice President of Quality. I oversee everything quality improvement for the AHA. Thanks for having us.
Hi, good afternoon. I'm Jamie Morgan with the American Heart Association and American Stroke Association, and I work in our Government Affairs Department.
Susan Ivey, UC Berkeley School of Public Health, and one of the Right Care team.
Right.
Michelle Moneyfield, Sutter Health, Stroke Coordinator for the Valley.
Lynette Wathen, Sutter Health Stroke Coordinator.
Great.
Sandy Myers, I'm with Dignity Health, I'm the Regional ACS Coordinator.
My name is Tom Poleg, and I work at Mercy San Juan with the Dignity Health Neurological Institute, and I'm the stroke coordinator.
Rich Otley, Mercy General Hospital. I also work for Dignity Health Neurological Institute and stroke coordinator for Mercy General.
Michelle Arroyo, I work for Dignity Health, I'm the Neuroscience Coordinator.
Afternoon, I'm Jim Connell with Genentech.
And John Spencer with Genentech.
Welcome. Great.
Hi, Rory Busudi, I'm Medical Director of California Health and Wellness, Health Network California.
I'm Steve Heath, Executive Director of National Health Network.
Hi, I'm Ms. Ashton, I'm from Madison, Johnson.
Sarah Garrity, Quality Healthcare Consultant.
I'm Martha Garrity, I represent HealthNet for Northern California Health Education Programs and the State League for Cardiovascular Health Education.
Good morning, my name is Katisa Cash and I'm with Bridgeway Medical Simulation Center.
Hello, my name is Heather Newmar and I'm the podiatrist at One Community Health. Hello, I'm Tracy Sizemore, I'm the Director of Nursing at One Community Health.
Hi, Jasmine Khan, I'm the Chief Medical Officer at One Community Health.
Hello, I'm Jim Ellsworth. I'm the President of Health Salute Equity.
Hi, I'm Farid Nasra. I'm the specialty care specialist for the state.
I'm Leslie Cummings. I'm a volunteer with the RightCare.Initiative.
Jimmy Pearson with Medicare, I'm Vice President and Chief Operating Officer.
Hi, I'm Victoria Mercado. I'm the epidemiology fellow at the Chronic Disease Control Branch of the CDPH.
Anita Watson, UC Davis, case manager at Woodward Case Management.
Sloan Nerby, Blue Shield of California, ACO Senior Clinical Program Manager.
Jan Pinkerton, Blue Shield of California, Clinical Program Manager.
Wow.
And I'm Kristen Robinson, I'm the Chief of Chronic Conditions Management for Kaiser and Sacramento.
Great. What a wonderful thing to have you all together here with us. We're so pleased when we can see the list of people who are coming. We've got a really nice selection. And so I have been attending since 2012 the University of Best Practices RightCare Initiative, and I had no idea anything about it until the Air Force brought me to California from overseas. And a good friend of mine, Brian Hayes, brought me to my first meeting that long ago. I was thinking it was 4, but no, it's almost 6 years. So time really does fly. So I'm very appreciative of the program that we have, of the opportunity to do what I've always loved to do, which is to share best practices, to get ideas spread about that will help us serve our patients better. I started in the Air Force. They were the way to get me through medical school and without debt, and decided that family medicine was going to be my role. I really love the idea of taking care of the whole family, from the elderly to the babies. And that's what intrigued me the most. And then I really appreciated the prevention that came along with that, and how important that became in my really 12 years of just practicing medicine full-time, to then being told by the Air Force that you're going to be a leader in clinical medicine. And so I became a chief of medical staff. And boy, what I loved about that was the medical management program that I was in charge of, and being able to get disease management underway. We had this was many, many years ago, but we had a PharmD who ran our high blood pressure program, and we're quite successful at that small Hill Air Force Base that is now still leading the way when it comes to prevention and medical management for the Air Force. Well, eventually, I, as was mentioned, came back to Travis Air Force Base, where I had served my residency and ended up in the command suite. And that was a wonderful opportunity for me, but nothing that trumps caring for patients and individuals when it comes to the kind of matters that we discuss in here. I remember at Ramstein in Germany having a young man, well, he's about 37, now it's young, back then that wasn't young, I guess, but he was a friend, a patient who had some risk factors. He had hypertension, but I wasn't, it was in the 140s, it's not that high. I hadn't really stressed it too much with him. He was a smoker, and I had stressed that to him. But after knowing him for a few months, being there, as the nurse came to me and said, somebody just walked in and wanted to talk to you because they think they're having a heart attack. And I said, okay, and I went out, and sure enough, I could see it in his face. He was certainly having an MI. You could just the look, and with just 2 leads, we saw the ST elevations, and we're on our way. Interestingly, I had a good friend at Landstuhl Army Medical Center, and I called him and says, "Oh, we're coming." He says, "Don't come here. We're not your best location right now for that. We don't have interventional here." And so we went to Hamburg down the road. I commandeered an ambulance, and we got him there. And because of the coordination with my friend who had called the hospital and everything was ready, when we got there, they were shaving his groin right out as we pulled him out of the parking lot. And he had a complete occlusion that they were able to open up and preserve his function. So we were very, that was burned in my brain from then on, and I thought I'll never take lightly these risk factors again. So now to be with you all, and we work on our best practices in getting our population in general to a healthier place. I'm excited to do that with you. I promised that I would tell, that I would pass on to you. I don't know if you knew that what Thursday, May 17th is. Maybe some people do know. That is World Hypertension Day. I didn't know it, but it is. That's this coming Thursday, and it's the National High Blood Pressure Education Month. And with that is, if you became friends, or how you do that on Facebook with the National Heart, Lung, and Blood Institute, you can join with them on the researchers will be answering questions and just giving the latest when it comes to hypertension and strokes. So, was there anything about that else, Hattie, that you wanted to mention?
Well, I just think it's wonderful that they're starting to do outreach to the public, and that we would have benefit of direct interaction with those NHLBI, National Institutes of Health, researchers on hypertension. And as many of you know, anyone who knows me, my mother had uncontrolled hypertension and died suddenly of a stroke when she was very young. So I think that one of the things that the healthcare systems need to be aware of is just because you're young, it doesn't mean you're immune. And so just as I said at the summit, the multi-generational impact when we lose a parent is critical. So some people say, well, why aren't you doing more for children? Well, frankly, this is the best thing you can do for children, is keeping their families intact. So thank you for teeing up that wonderful story. And if you wouldn't mind introducing Dr. Howard Backer.
My pleasure. Absolutely, thank you. So Dr. Howard Backer is the director of the California Emergency Medical Services Authority, EMSA, and he's been doing that since 2011. He's the executive chief and the medical director. So that's a great, I love to see both of those combined. Dr. Backer has been, he was even for a time interim director of the California Department of Public Health, so a tremendous background. And I just, talking to him, his favorite job ever was, he was doing some rural medicine in some beautiful places like Yosemite. That's hard to beat. But now he's running things for the state and for emergency services to help our paramedics, who we'll hear from as well, to ensure that we've got all the tools that they need for the best standard of care, and I appreciate it for you being here.
Well, good afternoon. It's a real pleasure to be here. This is my kind of audience, is people who are focused on quality patient care and not focused on the economics and payment sources, or but focused on doing the right thing for our patients. I'm an emergency doctor by original training and spent 25 years in various emergency departments, and mostly in the Bay Area. And then late in my career, I did a preventive medicine residency and made a change to the state because the emergency department did not seem like a good place to grow old. And I've had a really great career at the state, starting in public health, doing immunization, and then did a lot of disaster and bioterrorism, and now emergency medical services. Most people don't know that there's an Emergency Medical Services Authority, and you would have a lot of reason to come in contact with them, but maybe I'll give you a few. We have three major areas of responsibility. And one is in pre-hospital care. We actually license paramedics, and since we license them, we discipline the licenses. We manage their scope of practice. And I'll be talking about a major initiative around their scope of practice today. And then we also are responsible for scope of practice across the board for EMTs and even public safety first aid. So when, and as they're expanding what I call the public scope of practice, it's been very interesting in the last 5-10 years what scope of practice the public has been given. Now we have Narcan, epinephrine, tourniquets, and it just keeps growing. So pretty soon, we expect everybody in the public to be having a big bandolier with all their medications and devices that they're walking around with. And then the second area of responsibility that's pertinent to this talk today is that we regulate the specialty care service system. And we do that through our partners at the local agency, much like public health. So the local agencies actually have the responsibility of creating systems, designating the hospitals, and we have the typical state oversight role and regulatory role. So that includes the trauma system, which is the original specialty care system that dates back to the 80s, the early 80s, and then the newer ones, stroke and STEMI, that are just being developed in the last 5 years about, and the emergency medical services for children, basically pediatric services. And then our third area of responsibility is disaster medical care. We have the responsibility, we partner with public health, as we do in many initiatives, and we are responsible for coordinating the medical response to disasters. So we actually, although, again, it's the locals that have the first responsibility to support the hospitals, when they run out of resources, they turn to the state. So we would actually be supporting your health systems, your hospitals, with personnel and equipment in a major disaster. So, with that being said, what we're going to focus on today is a little bit of our specialty care systems, and I want to make sure you understand a little bit, a broader view of these systems, and then I want to get to a paramedic initiative that I think you'd be interested in. So, if you think about specialty care systems, what's unique about these is that they're really, first of all, they're clinical systems of care, and they're time-sensitive conditions. Trauma, stroke, STEMI are all very time-sensitive, and pediatric emergencies if there's a seriously ill or injured child. And what, though, is most unique about these is that we're looking now at integrated protocols that start in the pre-hospital environment and go through the hospital, through the emergency department, hospital, and all the way into the rehabilitation phase. And we're connecting the very beginning of those initiatives of care with the very end of the care and looking at outcomes. And I think that's astounding, and it really speaks for the quality and performance improvement process and how it's evolved over time. And it relies on data from the entire system. So, you can't evaluate the stroke system in your community by only looking at your hospital data. You're going to have to go extend out on either side. Let's see. There we go. So this is a typical, diagram from a hospital looking at door to needle time, but this is only part of the picture, because what happened before they hit that door could have a huge impact on the overall timeline, and then what happens after they get the TPA in terms of the outcome is also important. So, really the system looks more like this if we're looking at, this is a, STEMI, not stroke. But, you start with the symptoms and the 911 call. And the 911 call has to recognize the likelihood or the potential of the system, the symptoms, get EMS there. They have to recognize and they have a role in diagnosis in the field, and then they alert and activate the system at the hospital. But even more than that, they have to determine which hospital to go to. So how many of you are, say, a designated STEMI or stroke system, comprehensive level? And how many of you are primary receiving level? So most of you are, have a role in these systems. But, we have to, it's our pre-hospital protocols that determine when do we bypass a community hospital, which may be closer, in order to get to one of the specialty care centers. And it's not an easy decision. And it's not done by a flip of the coin. It's not done by the paramedics just thinking, well, they have better donuts, at this other place. It's done by medical protocol. Everything a paramedic does, they are not independent practitioners. They operate under medical protocol. And the statutory authority for their protocol is the local EMS agency medical director. It is not me that writes all the protocols for paramedics in the state. I try to marshal the local EMS directors to be consistent and to have the top quality or evidence base in their protocols, but they are the ones who actually write the protocols they follow. And so this is kind of what it looks like, the system looks like for reperfusion for STEMI. And I'm not going to walk through this with you, but there's two. Now there's kind of two different arms. One is just getting the thrombolytic in, and the other is getting the mechanical intervention in, for percutaneous intervention. Let's see, go on here. So let me just so you understand who has responsibility for what parts of this system. EMSA, my agency has the oversight, regulation, and guidelines. We approve of local EMS agencies' plans, and those plans include everything from their paramedic plans and which ambulance companies operate, who does the transport, which is all very political, and I won't get into it here. To they're approving their specialty care plans. And then we have some responsibility for performance improvement and assuring that there's QA performance improvement done. And I already mentioned that we do this in practice. So right now, I'll just give you an example. The medical directors have applied and want want to be able to give thrombolytics during transfer. So if they ended up at a primary center and need to be transferred to a comprehensive center, they don't want them delaying until the thrombolytics are done and then get on route. They want the paramedics to be able to monitor that drip on route to another hospital to save time. And they already can have optional scope of practice to get blood products and other things in trauma. So, but that's something that we can, that at the state level that I can authorize and that we will be looking at, to ensure that paramedics wouldn't make the decision to start it, but they could monitor en route. Then your local agency is the one that designs and implements the system, and they actually designate the different levels of facilities. And the medical protocols actually come from the local medical director, as I suggested. And then you have your EMS providers. Now, those are the agencies that actually manage or own the ambulances and hire the paramedics. So they have to have the resources, make sure their paramedics are trained, and report up to us. We do the discipline for paramedics, but we have to get the reports from the locals. And the facilities and health systems where you all operate, you of course have your resources of personnel and have to meet the guidelines and best practices for these, in order to be designated as a facility. So you are really the ground zero for quality assurance and quality improvement. And you may elect to have your facility verified by one of the associations. And those associations may be Joint Commission, or it may be American College of Surgeons, but then we're all operating kind of on clinical recommendations from the specialty care organizations like Heart and Stroke, Joint Commission, and others. Now, when this whole thing started, remember, public health had a role. They came to us and they were working on the guidelines, or what kind of the argument for the premise of these specialty systems and why we needed them and how they'd operate. And, you know, I still remember, you know, them bringing the white papers over to, and saying, you know, we need to be working on this. And we've really come a long way in a short time. So if we look at the STEMI system and how it's going to operate, you know, the care begins when EMS arrives at the patient's side. And that's usually when they start the clock ticking, because it's not fair to count when, you know, the time for an ambulance to arrive. But once they're at the patient's side, then they need to get the EKG to make the diagnosis and activate the system, and then make the destination decision. Really, the rate of false activations is relatively low in STEMI, but there's very clear diagnostic criteria that you can read off of an EKG. And we can now transfer or send those EKGs ahead to the hospital to be read as well, and many systems do that. Now, when we look at stroke, it's a little different, and you know, they just put out stroke guidelines, and then they pulled them back and revised them, which is really unusual. But what's happening in stroke is that we have such rapid evolution of the science that I'm gonna say caution here, because I've been around in medicine long enough to see at least half of the things that were just the greatest and newest treatments ever come and go. And because at first they're just great, then they're the standard of practice, then somebody takes the trouble to actually do some good research, and they find, maybe this isn't as effective as we thought, and then it's found to be harmful, and they withdraw it. So, you know, we got to be a little bit careful. I think we're going in the right direction, but I'm a little bit of a skeptic and don't believe I'm jumping on bandwagons too quickly. But I have to give a little bit of criticism to the Heart and Stroke Association, because they're a little too eager to adopt, you know, some of the new science instead of waiting for confirmation. So anyway, the stroke system works pretty much the same way, but we have to, just like STEMI, we have to educate the public as to what the symptoms are and get them to call 911. We still have about 50% of strokes showing up being driven by their spouse or relatives, or driving themselves to the hospital with a stroke. You know, only about half of the people are calling 911. So then the paramedics for stroke are using a stroke assessment system, you know, a stroke assessment score. And there's several of these scores, but they're not as good as elevated ST segments on an EKG. They're not that objective. Their sensitivity is pretty good, but there's a lot of things that there's a lot more false positives for stroke than there are for STEMI, you know, in the field diagnosis. And these things are things that cause, you know, weakness and some alteration in their level of consciousness. You know, it might be sepsis, it might be hypoglycemia. I mean, they could rule out hypoglycemia in the field, but it's a little harder. But they do begin some management in the field and again notify the hospital. So here were some of the other corrected guidelines that just came out. They want the triage protocols to use for identification, even though their sensitivity is not super high. And they want regional systems of care, but that's what these systems really are. They're, in other words, if one hospital can't provide the services, you go to one that can. And the hospitals have relationships to transfer among them to get the patient to the right patient to the right level of care at the right time. And you know, the first step is to get the thrombolytics in, and then now, and this is the most recent stroke, is they're going after the clots. They're not putting stents in the brain, but they're actually extracting the clots. And the question is when do you bypass the closest center to go to a thrombectomy capable center? And that is not as clear yet, although that's the